Hello, my name is Meg Huang. I'm the Executive Director at the Center for Connected Health Policy, and today I'll be talking about the recent changes in Medicare as relating to FQHCs and RHCs in this COVID-19 crisis. Few disclaimers today. Any information that I provide today should only be considered information. It is not legal advice. If you are looking for a formal legal opinion, please seek out legal counsel. Also, if I happen to mention a company or show some type of product, please know that neither I nor CCHP has any type of financial arrangement or relationship with such an entity. So the Center for Connected Health Policy was actually established in 2009 as a California telehealth policy organization. We're a program underneath the Public Health Institute, and in 2012, we applied for a grant through the federal government through HRSA to be the federally designated National Telehealth Policy Resource Center. We received that grant and have been serving in that capacity ever since. We also work on a variety of other projects related to connected health and telehealth with a variety of partners, and you'll see some of them that are listed on the screen in front of you. Some of the projects that we do include doing a 50-state compendium of all of the state laws, Medicaid policies, and regulations related to telehealth. We do that, keep that updated. It's updated twice a year, the spring and in the fall, and the spring update should be coming out within the next couple of weeks. We also act as the administrator for the National Consortium of Telehealth Resource Center, and we also are the convener for the California Telehealth Policy Coalition, which is an organization that has over 70 statewide members who are interested in telehealth policies in the state of California and advancing them. The National Consortium of Telehealth Resource Centers is made up of the 14 telehealth resource centers who also receive grant funding from HRSA. We all work collaboratively together in order to maximize our resources and also to be more efficient in how we use them and to have a consistency in the information that's put out. There are two national centers. CCHP is the one on policy, and there's one on technology as well. And then there are 12 regional resource centers that cover specific states. So I always like to say, if you reach out to one TRC, you actually get 14 of us because we work very closely and collaboratively together. This is a picture of the interactive map on our website. I had mentioned our 50-state compendium on Medicaid policies and state laws and regulations related to telehealth. So you can click on that map. All that information is publicly accessible. You can click on that map to bring up a specific state's information in several categories as well. And as I said, we do keep it fairly updated. The information on the website right now is good through October 2019. We were in the midst of the spring update when COVID-19 hit, so the information will be updated in a couple of weeks, and that information will be good up through February 2019 because, as you can imagine, this is a rather intensive process with a lot of information and a lot of man hours put in to like just gather that work. So it will be good up through February 2020, and that information should be updated within the next couple of weeks. However, today what I wanted to talk to you about was Medicare, not necessarily the states, but Medicare policy as it relates to federally qualified health centers and rural health centers, or FQHCs and RHCs. So prior to COVID-19, underneath Medicare, federally qualified health center and rural health center could not act as a distance site provider in the Medicare program when providing telehealth services. So what that means was they could act as the site where the patient was located, but they couldn't act as that, usually what would be a specialist or that provider at the end who was using telehealth to provide a service directly to the patient. However, in the CARES Act that was passed a couple of weeks ago, they did make a change in law regarding that. They did say in an emergency, public health emergency situation, an FQHC and RHC may act as a distance site provider when using telehealth for Medicare. What does that mean though? So it was a little bit vague in that, how are they supposed to do that? Where were the rules that they had to follow? And there was a bit of a lag time as CMS worked through those issues, and they finally issued a guidance today, April 17, 2020, in exactly how that should be carried out by FQHCs and RHCs. So a couple of things that they've done, and we've organized this on like what are some of the common questions that would come up and like the responses and the guidance that CMS has provided. So one of the first things is like, what modality can I use? Can I now use like live video, remote patient monitoring, and store and forward? And what CMS has said that is you basically need to use live video. You need to have an interactive audio and video telecommunication system, and it needs to be in real time. Now that is if you are providing a service via telehealth, or what they have classified as a service that is provided by telehealth. So there are other types of services that CMS allows that use telehealth technologies that they don't call telehealth. They call them virtual communication services. So, but for telehealth services, you have to use the live video modality in order to provide the services. So can any provider in my FQHC or RHC provide the services via telehealth, or does it only have to be a doctor? And CMS has said, like any healthcare practitioner, as long as they're working within their scope of practice and they're at an FQHC and RHC, can actually use telehealth to provide a service. What happens if my practitioner is at home providing the services? They're not within my four walls of my FQHC and RHC, and CMS has said that's fine. They can do that from home as well, because we have run into that issue. Perhaps you know, somebody's day off even, or perhaps somebody who might have to like quarantine themselves because perhaps they've been exposed to COVID, but they're still able to like, you know, work and provide services. So yes, they can be at home and when they're doing that, and CMS has said like Medicare will reimburse for that if they're at home providing that service. But what are the services that are provided? So even underneath, not for FQHCs and RHCs, just with Medicare in general, with their policies on telehealth, they have a very specific list of services that are the only services that can be provided and covered when using telehealth. So the FQHCs and RHCs will still need to follow that list. So if they are not, those services are not on that list that they have allowed, then they cannot use telehealth and expect to get reimbursed by CMS. They can use telehealth to provide the services. CMS and Medicare is just not going to reimburse them for it. But that link there, it's a link to the actual list of services that they will cover. The CMS will cover underneath the Medicare program if the service is provided via telehealth. So you can click on that to see exactly what those services are. So a big important question that FQHCs and RHCs ask is like, will they get their usual rate? And the answer is no, because actually in the CARES Act, they specifically said that the FQHC or RHC will not get their usual rates. They'll actually get a rate that's based upon a methodology that's created by CMS that will be using as a base the fee for service schedule. So what that methodology, the amount it's come up with, is $92. So telehealth visits will be paid at $92, not at an PPS rate and not at an error rate. So if you don't get their PPS rate, does the Medicare Advantage wraparound payment apply to these services? And CMS has said like, no, they won't apply for this. What about copays? Are we expected to do copays? So what CMS has said is that for services related to COVID-19 testing, and even if they're done via telehealth, FQHCs and RHCs have to waive the collection of coinsurance from beneficiaries. Now, those are just services related to COVID-19 testing. So if you do that, you use your CSS modifier in the service line to show that you have done that. They did not say anything else about copays related to services that were not about COVID-19 testing. They've only put that information in their particular guidance menu. Will the cost for providing telehealth be used to determine the PPS error rate? And they have said no, they haven't, and they have given specific instructions on like, you know, where to capture that cost. You have to report it still, and they tell you exactly where to report it, but it's not going to be used to determine your PPS and error rate. Do I need to get informed consent for this? So underneath telehealth, there was never a requirement to get informed consent. However, in some of those care management and virtual communication services, you do need to get consent. So that's still standing, but you can get at the time the services are being furnished, and you can also have it be obtained by somebody who's working underneath the general supervision of the FQHC, RHC practitioner. It doesn't need to be the actual practitioner themselves getting that informed consent. So how do we do all this? What do we do with billing? So this is where it gets a little bit tricky. So for claims, for services that were provided from January 27th to June 30th, they're saying use the modifier 95 on the claim, and the FQHC and RHC will be paid their PPS error rate. And that is because they don't have the system in place yet until July to calculate the rate that they're going to give you, which is the $92. So you're not actually getting your PPS air rate. It's going to show up that you are getting it for this period simply because they don't have the system in place just yet. They're just trying to like get this into place for people to be able to start providing services and start billing. But what's going to happen is that they'll recalculate it in July once they have the system in place, and they will recoup your costs. So just keep that in mind, in that, and you start seeing from like, you know, January to June that, oh, we're getting getting our PPS or my air rate. You're not going to keep that. They're going to go back and recoup that and recalculate it. And that's simply because we're all moving so fast. They just have not had their system in place yet to do the new calculation of $92. So from July 1st to the end of whenever the public health emergency is declared, what you will need to do, bill, is that you need to bill it with G2025. So that would be the new code you use, and that will calculate it accurately. Hopefully it doesn't, but if this public health emergency period extends beyond December 31st, 2020, they will recalculate the rate, that $92 rate, based on the 2021 physician fee schedule. So that is something to be aware of. Again, I want to stress, from claims from January 27th to June 30th, it may look like you're getting your PPS air rate. You will not be getting that. They are going to recoup those funds. It's just simply an administrative thing, in that they don't have the system in place and don't expect to have that in place until July. So they'll be like, you know, taking some of that money back. So keep that in mind when you're doing this, when you're doing telehealth and you're doing your billing and your accounting and so forth. Virtual communication services. So I mentioned this earlier, in that when there have been questions of like, can we use phone, can we use other modalities? And I said earlier, no, you can't if you're providing a telehealth services. However, there are services that they call virtual communication services that you can use other modalities for in order to provide those services. And CMS does not regard these as like telehealth services. They're called virtual communication services. They use telehealth technologies. They use these other types of technologies that come underneath telehealth, but they're just not called telehealth by CMS. So what are some of the things that FQHCs and RHCs can use? They can use the virtual check-in codes. So that's the G2010 or G2012 codes. That provides, like, you can do it over live video or asynchronously or through telephone. They are also allowed to use online digital evaluation and management services, and these are non-face-to-face, patient-initiated digital communications that take place over secure patient portals, and those are codes 99421 to 99423. Now, these are the types of services. I put those codes there so you know what the definition is for those types of services. But what an FQHC and RHC will use to bill for these services is actually the G0071 code. So you would use G0071 to bill any of like the previous codes if your service falls into that definition of that code. And then it can be also billed either alone or other payable services. Does not pay a lot because these are considered to be more triage, quick services. So G0071, if they're submitted on or after March 1st of this year to the end of the public health emergency, they will be paid $24.76 for each visit or each service there. So there is no limit though on like how often you use the G0071 code. So again, keep in mind, if your service falls into the definition of any of those above codes, the G02010 or G20112 or the 99421 to 99423 codes, if the service falls into one of those definitions, you can bill that, but the code that you're using to bill is G0071, and it will pay $24.76. So hopefully that was clear for folks. Now, one other thing I do want to say though, everything that I said beforehand, it just deals with Medicare and FQHCs and RHCs. Your state Medicaid policies may be different. They can be narrower, they can be broader, but they are possibly going to be different than what Medicare has issued. So keep that in mind too when you're doing billing or trying to provide services. Look at who the payer is for that particular patient that you're doing it for. Their policies may not be what the Medicare policy is because they may be a Medicaid patient or they're with a health plan of some type. So keep that in mind as well. Here are a couple of resources on the CCHP website that you can provide. If you wanted to read the CMS guidance for FQHCs and RHC, I did have that link earlier in the presentation, so you can go ahead and click on that and read the full CMS guidance itself. And I just wanted to thank you, and hopefully this has been very useful to you, and we will be back with another video for another topic next week. So thank you.